Hi everyone, so I'm Kabeer Shamsoodeen and I will be covering dependent personality disorder, which again falls under cluster C of personality disorders in the DSM-5 TR. So let's take a look at what we'll be covering today. We'll be covering what is DPD or dependent personality disorder, the DSM-5 TR diagnostic criteria for dependent personality disorder, key concepts, what it means to be someone with DPD, and the comorbidity. We'll also be covering the etiology, the gender aspects, prevention of DPD, and the impact on loved ones. So, what is DPD? So, dependent personality disorder is a chronic condition characterized by pervasive and an excessive need to be taken care of, leading to submissive and clinging behaviors and fears of separation. So, taking a look at the DSM-5-TR diagnostic criteria for dependent personality disorder, we're looking for someone with a pervasive and excessive need to be taken care of that leads to submissive and clinging behavior and fears of separation, beginning by early adulthood and present in a variety of contexts, as indicated by 5 or more of the following criteria. So, criteria 1 being has difficulty making everyday decisions without an excessive amount of advice and reassurance from others. Criterion 2 needs others to assume responsibility for most major areas of his or her life. Criterion 3 has difficulty expressing disagreement with others because of fear of loss of support or approval. Please note, do not include realistic fears of retribution. Criteria 4 is has difficulty initiating projects or doing things on his or her own because of lack of confidence in judgment or abilities rather than lack of motivation or energy. Criterion 5 goes to excessive lengths to obtain nurturance and support from others to the point of volunteering to do things that are unpleasant. Diagnostic criteria continued. We go to criteria 6. Feels uncomfortable or helpless when alone because of exaggerated fears of being unable to care for himself or herself. Criterion 7 urgently seeks another relationship as a source of care and support when a close relationship ends. Lastly, criterion 8 is unrealistically preoccupied with fears of being left to take care of himself or herself. So once again, I have a little mnemonic, and this time the word is reliance in order to remember the diagnostic criteria. So as we know, we need 5 or more of these letters in order to diagnose DPD. So the word is reliance. R standing for reassurance, E expressing disagreement difficult, L life responsibilities, I initiating projects difficult, A alone, N nurturance, C companionship, E exaggerated. So R being reassurance, which is the diagnostic criteria 1, which is has difficulty making everyday decisions without an excessive amount of advice and reassurance from others. E being diagnostic criteria 3, which has difficulty expressing disagreement with others because of fear of loss of support or approval. Then we have L, which is diagnostic criteria 2, which is needs others to assume responsibility for most major areas of his or her life. Then we have I, which is diagnostic criteria 4, which is has difficulty initiating projects or doing things on his or her own because of lack of self-confidence in judgment or abilities rather than lack of motivation or energy. Then we have A, which is criteria 6, which is feels uncomfortable or helpless when alone because of exaggerated fears of being unable to care for himself or herself. Then we have N, which is nurturance, which is going to excessive lengths to obtain nurturance and support from others to the point of volunteering to do things that are unpleasant. Then we have diagnostic criteria 7, which is C, which is urgently seeking another relationship as a source of care and support when an old close relationship ends. Lastly, we have E, which is the last diagnostic criteria, which is this person is unrealistically preoccupied with fears of being left to take care of himself or herself. Next, we have the key concepts of DPD. So, dependent personality disorder typically manifests in early adulthood and tends to persist over time, affecting various areas of life. Individuals with DPD often struggle with making decisions and initiating tasks on their own, relying excessively on others for guidance and support. Individuals with DPD may experience challenges in their professional lives. They might avoid seeking job promotions or taking on additional responsibilities due to their fear of making decisions independently or facing criticism. People with DPD may have difficulties in forming and maintaining relationships due to their excessive need for reassurance and support from others. However, once they establish a relationship where they feel secure and valued, they may become deeply attached and reliant on the other person. Risk avoidance and constricted lifestyle. In terms of risk avoidance and constricted lifestyle, individuals with DPD may exhibit a tendency to overestimate potential risks and dangers in everyday situations, leading to a preference for routines and avoiding situations where they feel uncertain or unsupported. So, what does it actually mean to be someone with DPD? So, firstly, we have dependency. They have a strong reliance on others for decision making and support. They have a fear of abandonment, which is a deep-seated fear of being alone or abandoned. They have difficulty with independence. They struggle with making decisions and managing tasks independently. Usually they have a low self-esteem due to a fragile sense of self-worth, constantly seeking validation from others. They have a tendency to subordinate needs. So they usually prioritize others' needs over their own and often neglecting their own well-being, personal well-being. Then they have vulnerability to exploitation, which is the susceptibility to manipulation due to dependency needs. Then we have difficulty setting boundaries. They struggle to assert boundaries and say no to others. And lastly, we have impact on daily life. It hinders their career advancement, strains relationships, and causes emotional distress. Okay, so moving on to comorbidity, there may be an increased risk of depressive disorders, anxiety disorders, and adjustment disorders. Dependent personality disorder often co-occurs with other personality disorders, especially borderline personality disorder, avoidant personality disorder, and histrionic personality disorder. Also, chronic physical illness or persistent separation anxiety disorder in childhood or adolescence may predispose the individual to the development of this disorder, DPD. Dependent personality disorder often co-occurs with substance use disorders. There's an increased risk of developing a substance use disorder, often as a means of coping with stress and low self-esteem. Moving on to the etiology of DPD, there's multiple factors involved. Starting with biological factors, a possible genetic predisposition and neurobiological difference could contribute to vulnerability. Then we have psychological factors where early life experiences such as overprotective or authoritarian parenting may shape dependency patterns. Looking at attachment theory, insecure attachment styles, particularly anxious, preoccupied attachment, may influence the development of dependency. Next is cognitive factors. Dysfunctional beliefs about one's own behavior and the world, such as exaggerated fears of abandonment or inability to cope independently, could lead to DPD. They may have social learning, observation, and reinforcement of dependent behaviors within family or cultural contexts could make an individual vulnerable to DPD. Etiology continued. So we have trauma and stress factors, which are adverse childhood experiences or significant life stresses that may exacerbate dependency traits. Then we have personality development, which is the interaction between genetic, environmental, and developmental factors shaping personality traits, including dependency. Next, we have interpersonal dynamics, which are relationship patterns that reinforce dependency or discourage autonomy, which may contribute to the maintenance of DPD symptoms. Lastly, we have the complex interaction, which is basically the biopsychosocial model. So it says that etiology likely involves a complex interplay between biological, psychological, and social factors with, with individual differences in susceptibility and expression. Next, we move on to gender. In terms of prevalence, dependent personality disorder is diagnosed more frequently in women than in men, though this may reflect gender biases in diagnosis and help seeking behavior. Next, we have the expression of dependency. Cultural and societal norms may influence how dependency is expressed, with women often socialized to prioritize relationships and caregiving roles. Next, we have social expectations. Gendered expectations regarding assertiveness and independence may impact the manifestation of dependency traits, with women potentially feeling more pressure to conform to traditional gender roles. Then we have the overlapping with gendered disorders. Dependent personality disorder may co-occur with disorders more prevalent in women, such as eating disorders and certain anxiety disorders, possibly reflecting shared underlying vulnerabilities. Lastly, we have treatment considerations. Gender-sensitive approaches to treatment may be beneficial considering how gender norms and socialization can influence experience and expression of DPD symptoms. So next we have prevention. Firstly, starting with early intervention, identifying and addressing dysfunctional family dynamics or parenting styles that may contribute to development of dependency traits in children. Then we have promotion of autonomy. It's when you encourage children to develop independence and problem-solving skills through age-appropriate tasks and responsibilities. Then we have emotional support, which is provide a nurturing and supportive environment where children feel valued and secure, reducing the need for excessive reliance on others for validation. Next, we have cognitive behavioral strategies, which is teach adaptive coping skills and challenge maladaptive beliefs about self-worth and competence. Then we have healthy relationship models, which is model and promote healthy interpersonal boundaries and assertive communication within families and communities. Then we have resilience building, which is foster resilience by encouraging the development of self-esteem, self-efficacy, and coping strategies to navigate life's challenges. Then we have education and awareness, raise awareness about dependency dynamics and provide education on healthy relationship patterns in schools, families, and communities. And lastly, early intervention programs. Implement programs aimed at identifying and supporting individuals at risk for developing dependent personality disorder, offering interventions to mitigate risks, risk factors, and promote resilience. Finally, we have impact on loved ones. Start off with role strain. Loved ones may feel burdened by the constant need to provide support and reassurance, leading to caregiver fatigue and stress. Then we have relationship dynamics. Dependent personality disorder can strain relationships as loved ones may feel overwhelmed by the responsibility of meeting the individual's dependency needs. Next, we have emotional toll. Witnessing a loved one struggle with dependency can evoke feelings of frustration, helplessness, and resentment. Then we have enabling behaviors. Loved ones may inadvertently reinforce dependency by accommodating excessive reliance on them, perpetuating unhealthy relationship dynamics. Lastly, social isolation. Both the individual with dependent personality disorder and their loved ones may experience social isolation if relationships become strained or if loved ones feel unable to cope with the demands of the relationship. Then lastly, we have impact on children. Children in families affected by dependent personality disorder may witness and internalize unhealthy relationship patterns, potentially influencing their own development of interpersonal skills and attachment styles.